Hi, everybody. That's what I want to hear. It sounded like 30 people in the room. That was great. All right. Next up, what do we have next? Well, next, we should thank the company that sponsored tonight's program, okay? There's only one company that supported tonight's program. I want you all to say thank you, Teva.
Thank you, Teva.
There we go. Great. Now, it's nice to see you because Dr. Kassicieh is here. Isn't that great? Great. Awesome. That's what I say. All right, so Dr. Kassicieh is going to speak with you about migraine. And this is something new that MS Views and News is doing. This year we're getting into migraine as well as all of our MS educational programs. Okay, you ready? Come on, let's welcome the doctor.
Thank you, Steve, for that. And I want to thank you all for coming out tonight. This is very exciting for me. I'm been here in Sarasota since 1987. I've been practicing both neurology and headache medicine during that time, and I've seen a lot of changes and a lot of advances in headache and migraine medicine over that time. Previously, I had participated in extensive clinical research studies and did some of the original clinical research studies in a drug you may have heard of, Imitrex, which the generic of which is sumatriptan. I did some of the phase 3B trials, and that was the last really exciting development in migraine headache until now, the 21st century. And that was all the way back in 1989, 1990. But Imitrex, which was the first, and subsequently we had a whole bunch of different triptans come out for the abortive treatment of migraine headache. And then Big Pharma didn't do much with migraine after coming out with 8 or 9 triptans as far as headache medicine goes until now, the 21st century. These are the drugs I was talking about, and we'll see that tonight. Were 20th century drugs, but tonight I'm going to talk to you about the one class, the 21st century first class of migraine preventative drugs, and that's really what tonight's talk is all about. I know this is sponsored by MS Views and News, which stands for Multiple Sclerosis Views and News, but I might rechange the name of your company here, Steve, to Migraine Syndrome, which is MS Views and News. How's that? Okay, so I'm going to talk to you tonight about the 21st century management and prevention of migraine headaches. The migraine program objectives are, number one, the awareness of the need to aggressively treat migraine headaches. The World Health Organization considers migraine to be the second most disabling illness worldwide. Does anybody know what number 1 is? Lives lost to disability. So it's not cardiovascular disease, and it's not cancer, because those patients die. It's chronic lower back pain. And so second only to chronic lower back pain is migraine. We need to understand what a migraine headache is versus just a generic headache. Migraine is a common disabling disease process, whereas a lot of people suffer from just chronic generic headaches. The classification of migraine used to be more necessary with old 20th century drugs, and as we'll see tonight, with the 21st century drugs, it's not really that critical. In migraine treatment, we'll go through the prevention, which is the primary objective in managing headaches and migraine disorder, and then abortive therapy, which are the triptans, is really a secondary consideration. And then I'm going to talk to you about the 21st century new drugs that we have for migraine prevention, and those are the CGRP blockers. And if you're taking notes, you can just write CGRP because it stands for this really long thing that I have up later, and you don't need to write that down. It is a chronic disease process similar to other chronic disease processes such as blood pressure, diabetes, and other illnesses that have chronic long-term implications for your health. It has a very low mortality, however, whereas untreated high blood pressure, untreated diabetes can be fatal. Migraine doesn't have that kind of mortality, but it has a very high morbidity, which is the disability that's associated with it. In the United States, there are about 40 million individuals affected with migraine headache, and the sad fact of the matter is, even with the new advances that we have in the treatment of headache and migraine, only about 60% of all patients that suffer from migraine are actually treated. That means that 40%, or about 16 to 18 million people, are walking around suffering needlessly, and particularly with today's access to these new medications that we have, there's no reason for that. Migraines are widely undertreated. Studies have shown that over and over again. And it is the most common medical cause of temporary total disability in the United States. Why? Because it predominantly affects people in the working age group, ages 20 to 50. Mostly female, it's about a 3-to-1 ratio. So we have a very high impact on the economy and the ability to work. Worldwide, there's about 1 billion, with a B, billion migraine sufferers. And of those, that's only a portion of it, because worldwide there are 3 billion headache sufferers. So to translate that, of the 3 billion headache sufferers, only 1 billion have migraine. So it's important to recognize that other generic headaches are twice as common as migraine. That doesn't make migraine any less disabling or cumbersome, not only for the patients, but for their families as well. As I said, it's a female predominant disease. And here in the United States, we have, there's episodic and chronic migraine. We have over 3 million chronic migraine sufferers, chronic migraine being defined as having 15 or more headache days per month. Now, that classification is arbitrary, I will certainly admit that, but it was important more for doing clinical research, but it's also important for patients who wanted Botox for their migraine, and I'll talk about that here in a little bit. Chronic migraine, which is CM up on your slides, CM stands for chronic migraine, has higher rates of disability. The annual costs are 4 times higher than that for patients with episodic migraine, and it has a high comorbidity. I'm sorry for the abbreviations, but it's hard to get all these words on one slide. Hypertension, coronary disease, high lipids, COPD, which is lung disease, psychiatric disease, and suicide. So we can see there are a lot of other disease processes that are associated with having chronic recurrent migraine headaches. Diagnosing migraine is the most critical portion of treating migraine. Again, there are twice as many people with chronic bad headaches as there are with patients with chronic migraines. And so we need to make that differentiation between what is a chronic generic headache and what is a chronic migraine. So the ICHD, or International Classification of Headache Disorder, came out with a very specific definition of what migraine headache is. And they're headaches that people have had at least 5 typical same type of headaches in their life. Duration is anywhere from a few hours to 2 or 3 days. And the important characteristics are that it's unilateral or one-sided. It pulsates. It feels like your heart's beating in your head. And very importantly, these headaches are made worse with movement. Now, if you took somebody with chronic generic headaches and you asked them, does it really bother you to go out and go to work or move around or mow the lawn? They may say, yeah, it's a little bit, but it doesn't really keep me from doing that. Whereas if you took a migraineur and you asked them the same question, they go, there's no way I would do that. I would be in bed with the lights off, some earplugs on, and ice pack on my head. That's what really differentiates migraine, is it's made worse by movement. And then additionally, they have light and sound sensitivity, photophobia and phonophobia, and or nausea or vomiting. So if you have 2 yeses in the upper ones and 1 yes to any of the lower ones, you probably pretty much have migraine. And the reason I say that is these new 21st century drugs that I'm going to be talking to you about work only for migraine headache disorder. Episodic migraine is less than 15 headache days per month. It's a very arbitrary classification, but it was used to get Botox approved. And basically, it's migraine. It's just less than 15 headache days per month. And you say, well, people can't possibly have that. Well, in my population of patients that I see, 15 to 30 headache days a month is the norm. So just take that into consideration. Triggers that can trigger migraine commonly are weather. We don't have any control over that. Alcohol consumption. That's a real problem because we can't control that. People even breathing the fumes, some patients I have are so sensitive, they breathe the fumes of any alcoholic beverage, and particularly wine, will trigger a migraine. Stress, menstrual period, smoke, foods, preserved foods, all can trigger migraine headache. So patients have to be aware of what their triggers are. I have people who say, well, I've seen these lists of food and I quit eating all those things and I still get migraine. Well, what I tell patients is you don't need to restrict your food intake only if you find a particular food triggers your migraine consistently. And then chronic migraine is merely 15 or greater migraine days per month, pretty much all the same characteristics as episodic migraine. But we need to exclude analgesic overuse headaches. And I have patients go, well, I only took, I'm picking on Excedrin now, I'll say that. It's nothing against Excedrin personally. I'm really doing good, doctor. I got my Excedrin usage down to only 2 bottles this month. 2 full bottles of Excedrin, is that all? Down from 4, they're doing good, they've cut it in half, right? We need it down to 2 tablets a month. Okay, so any drug, it could be brand name X followed by the word migraine. Taking too many of those results in more headaches, because the more headaches you have, the more medicine you take. The more medicine you take, the more headaches you have. It's literally like pouring gas on the fire. You're adding to the problem. Then we need to exclude other causes of bad headache, which are actually very common. Those being occipital neuralgia, which is pain at the base of the skull, but it can radiate all the way to the front, and then cervicalgia, which is a lower neck pain problem. So we need to exclude those because those are non-migraine headaches that can be very bad, and actually severe occipital neuralgia can mimic a migraine headache. So remember, chronic migraine is not the same as chronic daily headache. That's the message. Progression to chronic migraine, about 3% annually of patients with episodic migraine progress to chronic migraine, so it's important that we intervene in those of you who may have migraine headache to stop you from becoming those people that suffer from 20 to 30 headache days per month. And with good early preventative medication intervention, we can stop that from happening. So I have patients all the time who are in their 30s, 40s, or 50s and said, oh, my teenage son or daughter has headaches, and I asked them a couple questions. I said, well, is it a couple times a year? Is it a couple times a month? If they tell me it's a couple times a month, I really encourage them to have them bring in their late teenagers or in their 20 daughters or sons to come in and see me, because I, as a headache specialist, would like to be able to intervene in patients having headaches, because headaches occur just as commonly in children and teens as they do in adults. That's an important message. So if in migraine headache disorder runs in families, it's a genetically transmitted disease. So if you have migraines, or your sister or your mother or grandmother has migraine and your child has headaches, then it's probably likely that they have migraine as well. And so the earlier that we can treat patients that have migraine and stop their migraines from occurring, the better they do on into adulthood and later on in life. So there are other risk factors for progression to chronic migraine, and there are many up here. Head injury. Remember, the brain never forgets. Concussions are cumulative. So if you had 3 bad concussions when you were younger and then you get more concussions when you're older, it adds to it from what happened when you were younger. That's very important. Sleep apnea, which is a breathing condition, which is a serious problem. Depression is very common. Stressful life events, and then controlled substance. So any type of narcotic or opioid usage repeatedly also contributes to the development of chronic migraine headache. As I already said, the World Health Organization ranks migraine as the #2 disabling illness in the world. It's associated with personal disease burden and poor quality of life. Oh, I had to miss work today, and gosh, my boss told me if I miss any more work because of my headaches, they're going to fire me, and patients are at risk for losing their jobs. I've had patients that come in and tell me, if I miss one more day of work, I'm going to lose my job. I've also had patients who are usually in postgraduate programs, but also in college, that said, if I miss any more work, I'm going to have to, or excuse me, school, I'm going to have to drop out of school until I get these headaches under control. And I actually have patients that drop out for a semester or so. They're coming to see me and let me get their headaches under control so I can get them back to usually college so they can finish their education and go on and become productive in their lifetime. But the sad fact of the matter is, and look at the bottom line, only about 5% of chronic migraineurs, and studies have shown this, only about 5% of patients with chronic migraine actually get the right diagnosis and the proper treatment. In this year of 2019, that's really, in the state of medicine that we have now, which is fantastic, it's really sad that only 5% of the chronic migraineurs get the correct diagnosis, #1, of chronic migraine headache, and #2, get the right treatment. So what we want to do is have comprehensive headache treatment, and there is a type of headache condition called multiple headache disorder. And so I'll see somebody that has migraine headache, but they have a lot of other headaches as well. Analgesic overuse headache, occipital neuralgia, neck pain or cervicalgia, and what they call their sinus headaches. Now, this is an important point. Write this down. Sinus headaches are like unicorns and leprechauns. They pretty much don't exist. What people interpret as a sinus headache is actually a form of a milder migraine headache. Because if you gave somebody a migraine abortive treatment, like one of the triptans that I just mentioned, their sinus headache will magically stop. So you need to eliminate causes, get them to stop using their over-the-counter analgesics, treat the occipital neuralgia and the neck pain, which is cervicalgia, and then educate patients about sinus headaches, that they're really mild migraines. And then finally, and very importantly, your patients need to keep a headache diary. So if you suffer from headaches, you really need to keep a headache diary. They have great little cell phone apps now that have great headache diaries, or you can just keep a log of your headaches. Because the headache diary helps the doctor to know how often you're having headaches and how long they last and what's associated with them, like what's the weather doing? When was your last period? Did you have any alcohol? Those type of things. And also it helps us as headache physicians to be able to see how effective our treatment is. Because it's not uncommon for me to ask my patients, well, how are you doing after a month worth of treatment? And go, oh, I'm just the same. And yet you look at their headache diary, and initially they came in with daily headaches, and now you look at their headache diary and they're down to 15 headache days per month, and you say, well, isn't that a 50% reduction in your headache? And they go, yeah, I never thought of it that way, because patients equate doing better with having zero headaches, which actually may not be the initial case. We'd like to get them down to zero headaches. So that's why the headache diary is so important, at least for the patient standpoint. So patient education on realistic expectations. I have patients that come in that have frequent headaches, frequent meaning 15, 20, 25 days per month, and they have had these for 30 or 40 years, and they think that I have a magic pill that can suddenly make these things go away in a day. That's not a realistic expectation. I said, okay, we've had headaches for 30 years. You need to give me at least 1 or 2 months for every year you've had headaches. So maybe in 3 to 6 months we can get you a lot better, because that's a realistic expectation, knowing that with acute intervention, and particularly as aggressive as I am about treating and preventing headaches, whether they be migraine headache or other headache disorders, that those patients most likely are going to be much better within 4 to 6 weeks. But I don't tell them that. What is it? Under-deliver and under-promise and over-deliver, right? Okay. So 3 to 4 months of aggressive treatment. Quick fix intervention, get off all the analgesics. That's drug X, migraine, get off all that. All aspirin, Bufferin, whatever, Motrin, Advil, ibuprofen, naproxen, any of those. And all narcotics. Certain narcotics have to go. I don't prescribe anybody narcotics. They're bad. We have enough of an opioid crisis in the United States. I'm not going to contribute to that. Studies have clearly shown that narcotics and opioid medications do not work for stopping headaches. Actually, overuse of them can make headaches worse. And they're addictive, and sometimes they can be fatal. Occipital and cervical nerve blocks, I mentioned those. And then start preventive therapy immediately. That means on the first visit. So when I see patients, I explain all this to them, and I start them on their preventive therapy on day 1. I hand them a headache diary, and I say, okay, we're going to put you on this medication for prevention. If they have these other headache syndromes in the neck, I treat those over the next couple of weeks, and I get them started immediately on therapy. Explain to them, and I do explain to them very carefully, why that headache diary is very important. I have a headache diary that's a month at a glance, and that's so you could just put May, June, July, and I ask them to bring that in all the time so I can look through there and see their number of headaches drop. So patients may, as I said earlier, patients could be 50 to 70% better and still tell you that nothing's changed, but the headache diary says differently. Comorbid conditions, neuropsychiatric disease is 3 times higher in the migraine population than it is in the general population. So you always have to be on the lookout for untreated anxiety, which is more common, and depression. But the depression can be subtle. Patients can be depressed and not even know it. So you need to ask the question. I've been doing this for a long time. I can pretty much pick up on patients if they're depressed. So I tend to use the antidepressants very aggressively in my migraine population. There's an added benefit, and we'll see this later, that the antidepressants are some of the most effective headache blocking medications that we have. So you're really killing 2 birds with 1 stone. 3 if they have anxiety, depression, and migraine. Blood pressure control is very important. I like my patients to run in the low normal range, not in the high normal range, because even mild elevations of blood pressure that would be considered normal in the non-migraine population can actually contribute to your migraine patients having more headaches. Obesity counseling and screening for sleep apnea. Actually, sleep apnea and obesity tend to run together, but not always. If If they're there with their spouse or significant other or somebody and they say that they snore, and then I hear them stop breathing because their snoring suddenly stops, and then it resumes a little bit later, that's a high index of suspicion for sleep apnea, and I order a sleep apnea test on those patients. And then finally, get your patient to do some type of exercise. Remember, sitting is the new smoking. Smoking is the new smoking too, so you want to get them to stop smoking as well. So these patients, I do cardiac, diabetes, and lipid screening if there is an indication for that. Depression, anxiety, as I said, very high. Depression's up to 50%. These numbers are from a study. 40% anxiety, I would say it's more like 60 to 70% in my population. And suicide is a real risk, and so you need to ask patients about that. It's a common comorbidity in all headache patients, and again, the patients may not be aware of that. So we need to treat them with the antidepressant medications, which I'm going to list in a moment because I also use those very frequently for headache, specifically migraine prevention. Sleep apnea is frequently not recognized. It's a very underdiagnosed problem. Patients are bothered by, and they may come in with complaining of insomnia. Nothing to do with sleep apnea. I just can't sleep at night. Well, that's because they have sleep apnea. Not always, but you have to think about it. Daytime fatigue, because they're not getting restful sleep because they wake up multiple times at night. They quit breathing, that's sleep apnea, and they kind of startle and wake themselves up, and they go back to sleep. And then they sleep a little bit, and then they startle themselves back awake. So that's very irregular and bad sleep. That also contributes to having more migraine headache. Get a sleep study. It's easy to get. You just order the sleep study, go to the hospital overnight, they hook you up some wires, and you just take a nap overnight, and then they get the recording. And it's a very easy answer. Either it's positive or it's not. But we need to treat that because untreated sleep apnea is not benign. It's a serious problem that's associated with a lot of other medical conditions. Obesity, diabetes, high blood pressure, high cholesterol, cardiac disease, including heart attack, cardiac arrhythmia, irregular heartbeat, and sudden death. You go to bed, you have untreated sleep apnea, stop breathing, then your heart goes into irregular heartbeat and death. So it's a risk, and we need to look for that. Not only in the migraine population, but for everyone, and I screen for that in everybody. I don't send them all for sleep studies, I screen for it. I ask the questions of their spouse, children, whatever. Insomnia and apnea, insomnia is common in the United States. And the problem is irregular sleep or insomnia is common in the migraine population. Irregular sleep patterns are a trigger for migraine headache. And so one of the things I do as a comprehensive approach to migraine treatment is get my patient's sleep hygiene under control so they're getting the same number of hours of sleep every night. So if they're good at 7 hours of sleep, which I'm happy with, so try to get 7 to 8 hours of sleep a night, I want them having 7 hours every night. That's Monday through Friday, Saturday, and Sunday. The proverbial weekend migraine, that's because they go to Disney and they sleep in and they get now 9 hours of sleep and boom, they get a headache. So oversleeping can trigger a migraine, too little sleep can trigger a migraine. Excessive daytime sleepiness, they're at risk for car accidents, risk of losing your job, dropping out of school. I've had sleep apnea patients that have had these risk factors, and I diagnose them with sleep apnea, the test comes back positive, you put them on CPAP, and they magically start getting good sleep, good breathing pattern, and their problem is under control. One of the things I want to mention is the bottom line here. Doing computer stuff, watching, let's say, action movies or some other overly stimulating TV program, watching the news, I don't care what channel you watch, video games, and eating late are all very bad for migraine headaches and also insomnia. So all of this contributes to insomnia. So I try to tell my patients, I counsel them, stay off your computer. Like for me personally, I won't touch my laptop after 8 o'clock at night because if I do, it's like drinking 3 Starbucks for me. Okay, and that's what it does for you and everybody else. The computer is way too stimulating, much like video games are. Get away from your computer, preferably before 8 o'clock at night. You have the whole rest of the day to do whatever you need to do on the computer. Try not to do it after 8. Watching news, who wants to watch the news anyway, right? That just contributes then to depression, anxiety. Just saying. Botox, is that the next one? Oh, we're already to Botox, look at that. Botox for chronic migraine. Now, I'm here to dispel some myths on Botox. Number one, the FDA indication for Botox for migraine headache is for chronic migraine only. So if you really think you need Botox, it's for chronic migraine only, as defined by the ICHD, which is greater than 15 headache days per month. And you have to have the diagnosis of migraine, not chronic daily headache. That's very important. And they looked at this, and there's virtually no evidence that Botox works for any other type of headache other than chronic migraine, not chronic daily headache. So that's very important. And then in order to say that Botox was effective, I have patients say, oh yeah, Botox really worked for me. Really? Well, you have 30 headache days per month. How many headache days did you have after you got Botox? Oh, I went down to 25. Well, that's placebo effect, I'll tell you that right now, because to really see a significant effect from Botox, you need to see a greater than 50% reduction in headaches after each Botox treatment, after meaning 4 to 6 weeks after the treatment. My patients that were really excellent responders to Botox would go from 30 headache days per month down to 0. And stay there at 0 for 6 weeks or so. That's a responder, okay? So there's a lot of misunderstanding about that. And the placebo rate for the Botox migraine trials is very high. It was about 40%. I actually participated in some of those original nationwide double-blind placebo-controlled studies for Botox as well. So Botox for chronic daily headaches, you need to get it approved by insurance and Medicare. Well, that's another trick. So they severely restrict that to chronic migraine only, and those patients needed to have an adequate trial and failure of other migraine preventative drugs. And there's several different classes, and the requirement is that they need to fail one in each one of those classes. That's the requirement. And then you had to show some response to triptan therapy so that you make sure you have the diagnosis of migraine and not just chronic daily generic headache. And they had to have more than 15 headache days per month. That's where the headache diary came in. I'm going to tell you why all of this is obsolete here in just a minute. And then failed, I don't know why, but some insurance companies want patients to fail physical therapy for the headaches, which makes no sense to me at all, but that's what insurance companies require. Here's the big lie. Insurance companies lie. Now, I know y'all don't know that, right? But you call your insurance company and go, I want Botox for my migraines or for my headaches because I saw it on TV and I know this will work for me. Now, you all have seen Botox commercials. They're all over the place, right, on TV. This is not an anti-Botox talk, but I just need everyone here in the audience and people that watch this video to understand why it's a problem. The media hype is Botox is the treatment for headaches. Well, no, it's not. It's the treatment for chronic migraine only. If you read the product circular approved by the FDA, it said it's FDA approved for the treatment of chronic migraine only. And the one I love is, well, my friend had it and it worked great for them. I want it too. And I hear that. And then insurance companies tell you guys lies. You call them up and say, we'll cover your Botox. Just have your doctor call us. Yeah, no, that's not going to happen because try to get a phone number. Then you get to be on hold for 3 hours, and then you get to talk to somebody that doesn't know what you're talking about. And I'm entitled to Botox because my insurance told me they'll cover it. Well, they didn't tell you under what very specific and highly restrictive circumstances under which they will pay for that. So authorization is extraordinarily time-consuming and painful for those of us that have had to go through that. The cost of a single treatment for Botox for chronic migraine, just the cost of the Botox alone, without the injection procedure, and that's the wholesale cost, you can look up on the internet, is $1,250. Well, there's no doctor that's going to eat $1,250 just for the cost of Botox if insurance isn't going to pay for it. And most patients don't meet the criteria. That's the important thing. So having spoken about Botox, we'll move on to the other things. I just want to point out one thing on this slide, which I think is very important. Even in the most carefully selected migraine patients, which would be my migraine patients that I have identified as having chronic migraine, failed 3 or more treatment therapies of different kinds of treatment, and had some response to one of the triptan drugs, that is a good patient for Botox. So even in the most carefully selected patients, only about 3 out of 4 of the chronic migraine patients will respond to Botox. That means there's about a 25 to 30% failure rate of Botox even in carefully selected patients. So it doesn't work for everybody. In migraine, prevention's the key. It's all about prevention, abortive treatment. Patients can treat themselves with over-the-counters, and you see what kind of trouble that gets into, which is that analgesic rebound headache disorder. So we want to prevent patients from having migraine in the first place. So the old 20th century drugs, which I've listed up here, and were the preferred therapy, were the antidepressants, as I mentioned earlier. Now, we have a whole bunch of antidepressants, and they all don't work particularly well for migraine. There are only very certain select antidepressants that are particularly effective for migraine prevention. And oh yeah, by the way, they happen to work for anxiety and depression as well. So while I might prescribe a lot of Prozac, and forgive me for using the brand names, but you all can understand the brand names as opposed to generics, which you wouldn't have any idea what they are. So I have to apologize that I've put the brand names because these are all available as generics now. So I was like one of the top prescribers of Prozac prior to May of 2018. But if you looked at my prescriptions for Prozac, 95% of the prescriptions for Prozac were for migraine prevention, not for anxiety and depression. 5% were. It does happen to be a good antidepressant. Lexapro and Celexa, which are kind of twin sisters of each other, they're also effective. That's it. Out of that class of drugs, which is the Prozac class of drugs, there's only 3 that work particularly well for migraine, that being Prozac, Lexapro, and Celexa. All the other ones don't work, so I'm not going to mention those. Effexor's in a class in and of itself. It's an SNRI, which is similar to the Prozac class, but it's still a separate class. Of all the SNRIs that we have, only Effexor, or venlafaxine, which is the generic, works particularly well for migraine. And then thirdly, we have the third class, which is this old class of drug, amitriptyline and nortriptyline, which is an old class of antidepressants known as the tricyclic antidepressants, which nobody uses for depression anymore because they weren't particularly effective. I actually was in training back when these were the standard drugs for the treatment of depression, and they didn't work very well at all. Then Prozac came along and just changed the whole game for everybody because now that they're very effective and have super low side effects compared to amitriptyline or nortriptyline. So the neurologists have hijacked amitriptyline and nortriptyline because they're great for pain management, non-narcotic, non-addictive pain management. They also have the added benefit of being exceptionally good sleeping pills. So here we have a non-controlled substance that will help regulate your migraine patients' sleep hygiene, so they're getting 7 hours of sleep every night, and they work exceptionally well for that. And they're not addictive. Patients can stop them on a dime, and there's no withdrawal, which is very cool. And they also happen to be extraordinarily inexpensive. And nortriptyline. So those are the only 2 of the tricyclic antidepressants that really work particularly well. And I mix and match those. This is prior to May of 2018. I'm going to tell you why that is. There are other migraine preventatives, Topiramate, valproic acid. Those are in the anticonvulsant family. I tend not to use those because they have a lot of side effects. But Topiramate has had a lot of press time and was actually extremely and continues to be extremely widely used for migraine prevention. Baclofen, which is a muscle relaxant, which acts so differently than any other muscle relaxant, you can't really think of it as a muscle relaxant, but it's my 3rd most commonly prescribed 20th century drug for headache and migraine prevention. So it works very well. Again, none of these are controlled, addictive, or habit-forming. And then finally, the beta blockers. Really, I have to tell you, the beta blockers are pretty much pre-1990. We don't really use those anymore for headache management. They have a lot of side effects, low blood pressure, passing out, slow heart rate, a lot of side effects, not worth using. But interestingly enough, for Botox, they required the patients to fail beta blocker therapy. So I put that up there for honorable mention only. So again, those were the 20th century preventive therapies. I started them immediately at first visit. So if they had irregular sleep, I would go with either amitriptyline or nortriptyline to get their sleep hygiene regulated, because that is the first intervention that you need to do, is get their sleep organized. And you need to counsel the patients on how you get your sleep organized 7 or 8 hours per night. So pick the initial drug depending on the comorbidities. So if I have somebody that has seizures, epilepsy, I might pick Topiramate, which is an anti-seizure drug, but that's also approved by the FDA for the prophylactic treatment of migraine. And then you need to use therapeutic doses. I put SSRIs, which is Prozac, SNRIs, which is the Effexor, the tricyclics, which are amitriptyline, nortriptyline, Baclofen, or Topiramate. What I found frequently is patients were on little tiny doses, 5 or 10 milligrams, Well, that's kind of like taking a baby aspirin for a full-blown migraine headache, okay? You all understand why that wouldn't work very well. Well, the same is true for the preventive medications. You need to get them up to a high enough dose to where it will actually stop and block a migraine. And I'm just going to throw out an example there. A typical antidepressant dose for Prozac, and I'm not picking on Prozac, it's just easy to use, and I happen to used to prescribe a lot of it, was 20 milligrams, and that worked just fine for anxiety and depression. But for migraine intervention, I'm using 40 to 80 milligrams. Now, 40 is the maximum recommended FDA dose, but there's nothing wrong with going up to 80. It's perfectly acceptable. And I'm telling you that the vast majority of my patients that are on Prozac are between 40 and 80 milligrams a day. Perfectly well tolerated, low side effect profile, and it's inexpensive because it's generic. And then Topiramate, then there's Baclofen, which I use, also works well. Baclofen's a good broad spectrum drug, so it works well for patients that have mixed headache disorders. So if they have kind of frequent, we call them tension headaches, they don't use the word tension anymore, and then they have occasional migraine, Baclofen is an excellent choice for those type of patients because it's very broad spectrum in blocking headaches. So Topiramate, which used to go by the brand name of Topamax, is also FDA approved for the preventive treatment of migraine headaches. The problem is Topiramate has a lot of side effects, one of them being reversible stupidity. I mean that literally. Patients come in and go, I feel stupid. And I say, well, it's probably due to your Topamax. But the other thing that's of serious concern is that it can affect birth control efficacy. And not wanting to have unwanted pregnancies, we have to be careful in the use of Topiramate in patients that are on birth control and Topiramate. And then Botox is only really indicated for about 3% of all the migraine population. So we've talked about all these migraine patients, and really comes down to it, Botox really is indicated for only about 3% of migraine population. That's not very much if you do the math of 40 million migraine patients. Now I'm going to contrast that to the 21st century migraine prevention therapy drugs, which are a completely new shift in the migraine prevention treatment protocol. And what they are is the CGRP monoclonal antibodies for migraine prevention. Now, who would have thought that you could use a monoclonal antibody, and you've all seen lots of commercials for those on TV for eczema and psoriasis and other autoimmune conditions. Who would have thought that you could take the same class of drug, monoclonal antibody, and develop one for blocking migraine headaches? Well, that's actually what Big Pharma did, and I have to thank them for that because it's the first time in 30 years that I've been so excited about a headache and specifically migraine prevention treatment. Because what the CGRP monoclonal antibodies are drugs that were designed and engineered from the ground up and then they built these things to do one thing, and that was to block migraine, and that's the only thing they're good for, is stopping migraines from occurring. Now, the FDA has approved these, and you have to say, well, that's pretty cool that they could actually build a monoclonal antibody, a protein that will block migraines from occurring. And that's what I wanted to talk to you about. And it's the first new anti-migraine drug treatment, preventive treatment, that's been developed in over 25 years. And CGRP, I told you, I was only going to say it once, it stands for calcitonin gene-related peptide. Big name, you don't need to worry about it. It's CGRP blockers. And CGRP, though, it's not a neurotransmitter, it's a protein neuropeptide, and it's released from the nerve center in the brain called the trigeminal nerve, which controls pain of the whole head. And it modulates and controls pain and vasodilation. And it's actually the most potent vasodilator or blood vessel dilator in the body. And it's involved in the early migraine cascade to full-blown migraine headache. So the new monoclonal antibodies block CGRP effect in the development of a migraine headache. And that's the important thing. And this is very exciting treatment, and I'm switching all my migraine patients that qualify for this drug, this new drug intervention, over to the CGRP blockers. So CGRP blockers for migraine headache. It's a completely new class of drug which prior to May of 2018 did not exist, ever. Nothing even close to them. They are a whole new class of drugs. And the CGRP monoclonal, and it's indicated for both episodic and chronic migraine headaches. So that classification of episodic and chronic goes out the door with the CGRP monoclonal antibodies. Because if you suffer from 4 days or more of migraine headache per month, 4 days or more, that's it, then you're a candidate for CGRP blocking therapy for migraines. That's it. So you don't have to worry about, well, is it less than 15 or more than 15? And so what the CGRP monoclonal antibodies do is they do one of two things. They either attach to the receptor and they block the receptor, which keeps the CGRP from attaching to the receptor and turning it on, or they block the CGRP itself, which keeps it from also attaching to the receptor. So either way, we're blocking CGRP from exerting its effect of triggering a migraine headache. These drugs have a very super high safety profile, unlike a lot of the monoclonal antibodies that you see on TV, and the narrator of the commercial has to talk like an auctioneer and read 3 pages of warnings, right? You get cancer and infections and death and blah, blah, blah. You don't have any of that with the CGRP blocking. So there's no drug-drug interaction. It doesn't affect the immune system at all. So because of that, we don't have all those big serious side effect risks, and we don't have the development of cancer with these drugs either. And there's no kidney or liver effect. So it's not metabolized by the kidney or liver, so we don't have to worry about that. And it doesn't affect the efficacy of birth control pills either. CGRP blockers for migraine, as I said, 4 or more migraine days per month. So that could be any migraine patient, a high-frequency episodic migraine patient. So you say, well, 4 days a month doesn't sound very bad. Well, yeah, it is if your migraine lasts for 2 or 3 days. So if it lasts each 3 days, that means you have 12 headache days a month. That's a lot. That's half the month. So it is a big deal. And then, of course, all chronic migraine patients that have real migraines are candidate for the CGRP blockers. It's a self-injected once-a-month therapy. Ajovy, which is Teva's drug, has a once every 3-month dosing option to it. All of them, including Ajovy, can be given once a month, and the other 2 are once a month. So you need to have all your migraine patients keep a headache diary. And once again, this theme is repeated because here we go, because there's a whole new class of drug, and they're expensive compared to the generic, inexpensive drugs. We need this for prior authorization. So the insurance company go, well, how do we know your patient really has migraine? And how do we know they really failed this? And how do we know the drug therapy is really effective unless you can count? And they require headache day count prior to treatment and then after treatment. So that's another reason why headache diaries are so important, because the insurance company won't approve these expensive drugs unless you can actually provide them with meaningful data, which I have my patients keep, and I enter it into my chart note on every single visit every month. So I tend not to have authorization problems because I document all this. Plus, they have to have failed other preventive therapies the 20th century drugs, they have to fail those. Well, if I have a patient that has had headaches for 10, 20, or 30 years, it's not going to be very hard to show that they failed other therapies. So I'm going to go through each one. There are only 3. So Aimovig was the first CGRP blocker. It's actually the only CGRP receptor blocker, and that was approved back on May 17, 2018. And I remember that because it was a Thursday evening at 5:30, and I got text notification that it got approved. Well, that was really great and exciting for me as a headache specialist, except I'm closed on Fridays. But that's okay. I had my list of 60 patients that on Monday, every one of those 60 patients got called to let them know that that was available, and we got them in and got them started. It specifically blocks only the CGRP receptor and doesn't touch anything else. It just goes in your body and blocks the CGRP receptor. Comes in 2 dosage forms, 70 or 140 milligrams. The recommended starting dose for Aimovig by the FDA is 70 milligrams subcutaneously once a month. Some patients may benefit from the higher dose. Having told you that, I would say that about 75% of my patients are still on the 70 milligram, and about 25% I've had to increase to the 140. But these patients are responding exceptionally well because you look at their headache diary and you give them Aimovig and their headaches just plummet down to somewhere between 0 and 3 very mild migraines a month. That's in my patient population. That's not on the product circular, but I'm giving you, now it's been out for a year because this is May of 2019. I have a whole year of data in my head to tell you how these patients responded. So it's obviously approved for both episodic and chronic migraine. They don't even mention episodic or chronic in the product circular. It just says for patients that have 4 or more migraine days per month. Side effects are minimal. Injection site reaction, it's a little tiny subcutaneous injection. The needle's only like 1/8 of an inch long. So they can have injection site reaction. You can give somebody a sterile saline injection, they could have injection site reaction. And constipation is the other side effect. That's not everybody, it's about 20% of the patients. But that's manageable, it's manageable, that's the whole point. So then you have the CGRP ligand or the CGRP molecule blockers. I meant to change that word ligand to molecule, but that's okay. Ligand means the molecule. That means CGRP itself. And Ajovy, which is made by Teva, was the first CGRP molecule blocker monoclonal antibody approved. And it happened to be approved on Friday, September 14, 2018. You say, well, how do you know that was a Friday? Well, interesting you should ask that, because actually Friday at 12:45 p.m. in the afternoon, I was giving this talk to about 300 physicians, and I told them all, watch the news tonight, because at 5:30 p.m., the news is going to announce the release of a new monoclonal antibody CGRP blocker. And sure enough, at 5:30, they wait till the stock market closes. That's why the 5:30 time. Wait till the stock market closes. And the news came out on the news at 5:33 p.m. that Ajovy was approved by the FDA for preventive treatment of migraine headaches. And again, the approval is the same, both episodic and chronic migraine patients that have 4 or more migraine days per month. Dosing is 225 milligrams monthly subcutaneous. Again, it's a tiny little shot, subcutaneous, easy to give. They're coming out with an auto-injector very soon, from what I understand. But it's a tiny little syringe, it's easy to give. And for those of you that have MS that do self-injection, it's way better than the MS auto-injectors. Or you can give quarterly 675 milligrams every 90 days. So that's pretty good for my patients that are traveling a lot and that aren't here a lot to get that. Now, I will tell you that the vast majority of my patients on Ajovy are getting the 225 monthly, because I want to look at their headache diaries, I want to see how they're doing. And the other important thing is, don't forget, these are patients I've been treating for 10, 20 or more years, and they're on all these other preventive drugs. Well, I'd like to wean away some of those other meds so they're not on 15 meds for their migraine headache prevention. So I try to wean those away. The first is Topiramate, that I want to get rid of because of the mental clouding and the forgetfulness side effect. But if I can get rid of the others, I will, Baclofen and those. I have attempted to wean my patients off of some of the antidepressants, and I classify them as antidepressants, even though I'm not really using them for that. And patients try to come down. They may get down a little bit, but they find that their depression, anxiety kind of creeps back up on them. So I've quit trying to wean those. If the patient's happy, I'm happy. So now they're having anywhere from 0 to 3 mild, super mild migraines per month, and that goes for Ajovy as well. And they're happy because they're on their happy pills as well. So I'm perfectly good with that. It's quality of life. That's what it's all about, is the patient's quality of life. So not only do you affect the patients, affect and improve, drastically improve the patient's quality of life, but you affect their marital quality of life, their relationship quality of life, their relationship with their kids and their family. Because I had plenty of patients that go, oh, I'm not going to go to Disney or Epcot this weekend because I just know I'll ruin my family's vacation because I'm going to have a migraine. I'm going to be in the hotel, in bed, throwing up sick. You now have eliminated that. For all the patients I've started on any of the CGRP blockers, they no longer have disabling migraines. And that is a question I ask them at every single visit. Have you had any disabling migraines since you got started on your CGRP blocker? And I will tell you the universal answer is no. That's pretty impressive for a disease that was disabling them anywhere from 5 to 15 days per month. That's huge. So, I mean, we need to think about this. So it's just not the patient's life you're affecting, it's everything else that goes along with the patient. Family, friends, work, school, etc. Side effect of Ajovy is just injection site reaction, then hypersensitivity reaction. Actually, the updated product circular on all 3 of these is hypersensitivity reaction. So in that sense, Ajovy is no different than anyone else. And it's a tiny, small injection as well. And then lastly, I did change it on, see, I have to remember to change that. I did change it. The CGRP molecule blocker, the last one approved was Emgality, made by Lilly. It is a CGRP molecule blocker, just like Ajovy. It targets the CGRP molecule, and that was approved about a week or 2 later after Ajovy. And so it was the 3rd one on the market. The indications are the same, 4 more migraines days per month, and you can use Emgality. Emgality was studied against Botox failure migraine patients. I will tell you that I've used the others in Botox migraine failure patients, and it has worked exceptionally well. Those patients that failed Botox responded exceptionally well to both Aimovig and Ajovy, and I have fewer patients on Emgality, but also that was studied against them as well. So all three work quite well for Botox failure patients. That's that 25 to 30% of the patients that have chronic headache that aren't responding to Botox are responding to the CGRP blockers. That's the important message. So the initial dose of Emgality is a little bit different. So you give them a double dose, 240 milligrams, and then monthly just a single auto injector of 120 milligrams per month. Side effects are virtually the same: injection site reaction, hypersensitivity reaction. Really, that is the total extent of the side effect profile. I mean, that's impressive compared to these other monoclonal antibodies that we see advertised on TV. Super safe, super low incidence of side effects, highly effective, 90-95% for any one given patient. That's a super high efficacy. None of the old 20th century drugs even came close to having that high degree of efficacy. That's why I had to have some patients on 2 and even 3 migraine prevention, old 20th century prevention drugs to get their headaches under control. Now we can just use one of the CGRP blockers and do well. And so if I have a patient that I know has already failed all these, I start them on a CGRP blocker and that's all they're on now. And their headaches are down to 0 to 2 or 3, super mild, quickly respond to a triptan, and they go about their day, and they don't have to miss any work, they don't have to miss any school, and they don't have to miss any family time or vacation. So abortive migraine therapy is a secondary concern for most migraine patients, and the therapeutic goal, and my goal has always been less than 4 headache days per month. This is long before the CGRP blockers came out. This is back in the 90s when I was doing this. My cutoff for being on preventive therapy was if you had 4 headache days per month, you had to be on preventive therapy. So my goal was to get them down to less than 4 migraines per month. Was I successful? Yeah, in about 90-95% of the patients. Some patients just had chronic intractable migraines, and you could lessen them, but they still had, and this is the important thing, they still had disabling migraines. I wasn't able to completely get rid of those until the CGRP blockers came onto the market. Now I've been able to eliminate their disabling migraines. We need to avoid analgesic overuse headaches, so I counsel everybody, don't be taking handfuls of all these over-the-counter analgesics because it's bad, bad, bad. It's like pouring gas on the fire. Triptans are the mainstay in acute migraine treatment. They come in tablets, and we have about 8 or 9 of those. The only one that was ever developed for an injection was the sumatriptan injection, which used to go by brand name Imitrex. You might be more familiar with that. It's sumatriptan now available. And then Onzetra is a nasal spray system, which is an interesting system which some patients seem to really like. NSAID therapy, which are the anti-inflammatories such as ibuprofen, naproxen. The gel cap preparations are better for an acute migraine, and they still are. They dissolve faster, they get in the body faster. So if you take a gel cap plus a triptan, that's your best bet for acute migraine treatment. Early intervention, take it early, take both, and then if you have nausea and or vomiting, you need to have some type of anti-nausea medication. There are several on the market, and again, forgive me, I've used the brand name, they're all available generically, Zofran, Reglan, and Phenergan. Now, of the 3, Zofran and Reglan are not sedating, whereas Phenergan is highly sedating, and so that's not particularly one of my drugs of choice because I want to keep the patient functional. So if they have a migraine at 10 o'clock in the morning, I don't want them taking a Phenergan and falling asleep at work because then you've just defeated the purpose of stopping their migraine, right? So I tend to use, my preference is Reglan. Some patients respond well to Zofran. They're both generic and inexpensive. And if they wake up in the middle of the night with a full-blown headache and they're already throwing up, you're obviously not going to be able to take any pills. So they need to have a sumatriptan injection and use one of the suppositories, either Phenergan or Compazine, again, brand name for medicine that's available generically. Because you got to shut that down. You really do. So that's the acute treatment. And that's all I'm going to mention on acute treatment because that's all there is. So the whole point is to keep your patients from having to get to the point of having to use the medications on this slide. But I have all my patients equipped with that because I don't let my patients go to the emergency room. I said, you call me before you go to the emergency room because I make sure that my patients have their Migraine Rescue Kit so that they don't have to go to the emergency room. And that's, who wants to go to the emergency room, right? That's not a fun trip. So here it is, Migraine Rescue Kit. So, ER trip kit, right? So the injectables, sumatriptan's the mainstay. Toradol is an injectable anti-inflammatory medication. And DHE45 is an old drug in the category of ergotamines, and it can be given as a self-injection. And that's for your patients that are triptan non-responders, which are extremely uncommon. And then anti-nausea and vomiting therapy tablets and mandatory suppositories. This is to keep your patients out and yourselves out of the emergency room. I don't like any of my patients going to the emergency room, so much so that I tell them on the first visit, because they go, well, I usually have to go to the emergency room 6 or 8 times a year. I go, you're not going to go to the emergency room anymore, because if I find out you did that without calling me first, you're going to hear about it from me, because it's unnecessary. And the ER treatment of headache is extraordinarily poor. I just read, I didn't write it, I wish I did. I read a really interesting medical report recently that the state of current medical treatment for headaches in the emergency room was graded as poor at best. So keep that in mind. I tell my patients that. Avoid narcotics altogether. They're addictive and habit-forming. Furanol, Furacet, generic on that's butalbital, hydrocodone, tramadol. No, that just doesn't work. You shouldn't ever use those for treatment of headache. Not to mention their addictiveness and the risk of death from addiction. So in summary, migraine disease contributes significantly to the burden of disease-related disability in the U.S. and both worldwide. Chronic migraine is associated with multiple system disease, cardiac, renal, high blood pressure, cholesterol, sleep apnea, and there's a higher incidence of neuropsychiatric illnesses, depression, anxiety, and suicide. So we need to be on the aware. This is not a benign condition, that's what I'm trying to say. Screen your patients carefully for comorbid conditions. So if you think you may be one of those people, you need to talk to your doctor about it. And then finally, treat extremely aggressively with preventive therapy, where they use some of the old 20th century drugs, which most patients that suffer from chronic migraine, whether it be episodic or chronic, have already been on those drugs. But certainly the new 21st century preventive agents, the CGRP blockers, are, in my professional opinion, the drug of choice treatment for prevention of migraine. And I'm really pushing that very hard. I push hard on the insurance companies to approve it, and I've been very successful in doing that. Documentation is a key. And finally, what you end up with is a dramatic improvement in the quality of life for both your patients and their family. You're maintaining their job, keeping them in school, and letting them get on with their life. And I just to that point, I just want to show you an illustration. So it's not uncommon for me to see patients that have had headaches, migraines, we're talking about migraines, for 20, 30, 40, even 50 years, decades, 2, 3, 4, 5 decades, and they've never seen a doctor for their headache. I think that's just shocking in the 21st century. I'm the first doctor they're seeing. So let's just take 40 years as an example. So if your patient has had 40 years of recurrent migraine, and let's say they're in the chronic migraine category, and they had, I'm going to put them on the low end of it, and they only had that's not particularly amusing, but they only have 15 migraine days per month. That means that of those 40 years, they're spending half their life, 20 years, totally temporary disabled, in bed, throwing up, incapacitated. 20 years of their life. Can you imagine spending the next 20 years of your life in bed, throwing up, incapacitated? Now think about that for a minute. Now just think if you can intervene in that patient at 10 years of having headache or migraine, and you start them on a CGRP blocker, you're effectively giving that patient that other 10 years they would have lost the next 30 years of super high quality of life. So I just put that out there for your consideration. And that is the end of this talk. I want to thank you all for coming. I want to thank MS Views and News and Teva for sponsoring this talk. And I have plenty of time for questions.
Great, thank you. Who has questions? I'm going to go around the room with this listen to me, with this microphone. You got me confused earlier.
Yeah, that's like one of those modified radar detectors, right? Or radar
yeah, something like that. Anybody have a question?
I'm going to have a question.
I have a question.
Okay.
Other than the side effects that you mentioned, since it's a monoclonal antibody, is JC virus a factor?
Is JC virus a factor? No. And so MS patients be very familiar with monoclonal antibody therapy because we have lots of things like that for MS. But in MS treatment patients, particularly with certain MS treating preventive drugs, JC virus is a serious concern, and we need to check for that. But since the CGRP blockers have virtually no effect on the immune system and don't interact with the immune system, as contrasted to the MS drugs, which all affect the immune system in some way, 100%, that's how they work, The CGRP blockers have zero effect on the immune system, the white blood cells, and any other part of the immune system. So no, JC virus is not a concern.
Great. Any questions yet? Great, because otherwise I had more. Got to get you started somehow, even if it's a microwave.
I don't really like those, thank you. Yeah, in one of the first slides, it said totally and temporary.
Temporary total disability.
Yes.
Yeah.
That contradicted to me, temporary and total.
Well, it is. So migraine is temporary because it's X number of hours or days, right? We're anywhere from 4 hours to 72 hours, and that's a self-limited attack. But that's a very good question, though. So during those 4 to 72 hours, that patient is totally, with a bad migraine, is totally, but temporarily disabled. They can't function. They're in bed throwing up. They can't stand the light. And so that is the reason for the major number one cause in the United States for temporary total disability.
Got it. What's MVA? That acronym that was up there?
MVA, motor vehicle accident.
Okay. And I think there was...
I apologize because I had to take a very high-level doctor talk and make it for the public speaking. Forgive me if I missed some of those acronyms.
There was one other, hypersensitivity reaction.
Right.
What does that mean?
Allergic reaction.
Okay.
Right.
Not different from a site, whatever you call it.
Well, now you can, it's different from an injection site reaction. So an injection site reaction would be a little redness, a little tiny lump or hardness because you're injecting fluid underneath the skin, right? So if you had a little 1 inch not hard, but firm lump, and it was a little bit red, that wouldn't be anything to worry about. But if you suddenly broke out in big hives, or just even up your arm or your whole body, that's a hypersensitivity reaction. And the most extreme form of that is an anaphylactic reaction where you're having wheezing and trouble breathing, your throat's closing off, and that's a bad reaction. Fortunately, those type of things are extraordinarily rare. They're also rare with the CGRP blockers. But the CGRP blockers are a protein, and if you inject protein, even though they're fully humanized, there's still a extremely low but not zero incidence of hypersensitivity reactions.
Question here? I got it.
I was listening from outside, and I don't think you talked about young women with migraines, especially when they're menstruating. Is there a relationship?
Yes, menses is one of the most common triggers for migraine in migraine patients. So I can have a woman of menstruating age, let's say 20 to 45, or actually earlier than that, it'd be 13 to 45, anywhere from menarche, when you start your periods, to when you go through menopause. So anytime during that time. And migraine headaches are commonly very cyclic. And so let's take somebody who has no other migraines except during their period. That's very common as well. So they have 2 or 3 days of bad migraine, and the rest of the month they're migraine free. Now those patients I wouldn't put on a CGRP blocker because you can do the acute intervention therapy that I did for 2 or 3 days and stop their migraine, and that's it. So it's either at the beginning of their period or at the end of their period is very common, or sometimes it's premenstrual, it's 2 or 3 days before. So some women are 2 or 3 days before, some are the first 2 or 3 days of the period, and some are the last couple of days of their period. And it varies, but it has to do with their menstrual cycle. And so in those patients, what I do is just acute intervention. Those patients are educated and they know to take their medications early. In some of those patients, I might give them a little bit of preventive therapy a week before in the therapeutic desire to minimize their migraine, although I won't stop them. I will tell you now with the CGRP block, and let's say that we have someone that has menstrual migraines, but they have migraines during other times of the month. That's the more common scenario. So those patients are usually on the old preventive therapies that I mentioned, but a lot of those patients now have been switched over to the CGRP blockers, and interestingly enough, their menstrual migraines have been eliminated. That's a big statement because before, menstrual migraines were notoriously the hardest migraines to treat, and you just had to load them up on the medications that we talked about for the abortive medications, which I can click back over here to. So there was wide use of all these abortive medications for those patients with menstrual migraines, including those that woke up in the middle of the night with a full-blown migraine, throwing up, and they needed to inject themselves with sumatriptan and give themselves some kind of suppository to shut down the nausea and vomiting. Interestingly enough, for the past year that I've been using the CGRP blockers, not a single one of my female patients with menstrual migraines has even told me that they've had a menstrual migraine. And my headache diary actually has that online. When is your period? So they mark the menstrual days so that I can see if there's a correlation between migraines. It's interesting that since starting the CGRP blockers, that correlation has gone away, which I think is really fantastic. Great question. Thank you.
Great. Before I get to the next question, for anybody that's taking notes here all tonight, remember that we are video recording, so this will be coming out in a few weeks, and when we publish it, we will send you all an email about this, so that way you can look back on it at that time. Now, the next question, I have this, and that is that obviously I don't have any menstrual migraines, okay, but
we hope not.
I
Now,
definitely do not have that problem, but I do get optic migraines, and I do get them like once every 6 months, and I saw that nothing was really mentioned about that because I don't have any of the nausea problems. I don't have any of the vomiting and whatnot, but I do get like a whiteout effect from the optic migraine as far as also being like in a Star Wars movie. But how does this medication work for that?
so when you say optical migraines, you mean you have just the visual aura of the flashing lights, or
Yes.
white out of your vision, or
Yes.
dark spots, or wavy lines, or those are typical visual auras and that's seen in about 20% of all migraine patients. So not even all actually more, 1 out of 4, 1 out of 5 migraine patients actually even has an aura. So there are patients that have pure migraine aura, optical migraine, visual migraine. That's common terms used for those. So if you just have the aura alone, we don't really treat those patients. I haven't really found a need to do that because it's benign. They don't have any headache. They're not disabled from it other than the visual trouble that they may have, but it's short-lived. Usually the optical migraines or visual migraines only last 20 to 30 minutes, and they're not serious, and they're usually not very frequent, just as much as you said, you have probably a couple a year. And I see patients that have anywhere from 2 to 6 or 8 a year. I just reassure them that no treatment, because they have no headache with it, so they're not disabled, other than the 20 minutes of visual trouble. Maybe they don't want to drive during that time. That's fine. But the visual migraines really don't need treated. Now, I have seen 2 patients in my entire career that had visual migraines every single day, maybe 2 or 3 times a day. Now, those patients I did do therapeutic intervention on, because that would become somewhat disabling if you can't see 3 times a day for half an hour, 40 minutes at a time. So those patients, I did intervene on them, but I would use some other therapy. I use verapamil, which is an old calcium channel blocker blood pressure medication that used to be thought of being as a really great migraine drug. It's not, but interestingly, that works particularly well for visual migraines. But again, in 30 years, I've only had to do that twice.
Sure. Sounds like they didn't really want to work, so they got a migraine
There you go.
optical migraine every day. Anybody have a question yet? Okay, next one. You ready? You spoke about the injections, and there's the small dosage and the larger dose. I have heard from other migraine doctors that said that for the 675, I believe, milligram dosage that you have,
Right.
that
That would be for a Jovi.
correct, that they are doing those injections in their office, and that they didn't recommend for patients to do it on their own. What is your theory on that?
I think it really depends on the patient. There's no reason why you can't let a patient give themselves their own quarterly injections. It depends. Number one, a Jovi is a tiny syringe with a needle, okay? That's different than an auto-injector that you just push against the skin and push the button and it just does it all for you. And I showed on my chest, you don't do that on the chest. I do all lateral, just for the record, I do lateral abdominal injections only. If you talk to most diabetics, they're giving themselves insulin. They do lateral abdominal injections only. Don't use your thigh. It's hard to reach around to your arm. So I train my patients to do lateral abdominal injections only, because even in your thinnest patients, your little 90-pound waifs, the highest concentration of subcutaneous fat is in the lateral abdominal regions, and I have those patients. It's a little bit tricky to give them the quarterly injection because there's not much. You have to do 3 different injection sites because it's actually not a 675 milligram injection. It's 3 of the 225 injections. But it comes like that in the box. And again, I don't really recommend that. I have only a couple patients that are on that injection regimen. I really recommend starting with a 225 a month dosage because, again, I want to see that fall off in their headache numbers first to make sure they're responding to a Jovi. And then if I have a 6-month headache diary worth of data that shows that their headaches have really fallen off to that 0 to 3 migraine days per month, then I'll switch them over to the 675 if they want to. But by then I've trained them to give themselves their own injection. But to your other question, the vast majority of my patients that are getting CGRP blockers, I do their injections in the office. But that's not because I want to do the injection, it's that I want to make sure they get it right and they do it right. And also that I want to look at their headache diaries and collect the data and wean them off of their other medications. But now that I'm about a year out on Aimovig and about 6 months out on a Jovi, I've trained probably 25% of my patients to self-inject, and a lot of them don't want to do it because they're needle phobic, which is fine. We don't charge the injection. It's just an office visit, and that's all. Not even a higher office visit, just a routine office visit.
It's funny, I just said that. You get another office visit.
No, I just do that. I don't upcode it. I just charge a regular office visit. We do that as a courtesy for our patients because I understand, after doing this for so many years, needle phobia. And to that point, since May of 2018, I have not had to give a single patient a Botox injection for migraines.
Great. Any questions yet? There we go. It seems like we're playing ping pong here.
Just, you said you got to shut it down. You really do. What is it affecting vascular? Or,
shut what down?
Well, you described somebody vomiting at night and shutting it
down. So you need to shut down the headache, but the headache specific drug. Why?
Is there a lasting effect?
Oh yeah. So the migraine abortive drugs may stop the migraine, but it won't necessarily stop the nausea and vomiting. And this is uncontrollable vomiting. I've had patients in my office with this from their migraine. So what we need to do is give them very specific anti-nausea and vomiting drug to number one, so they're going to take their shot of sumatriptan because it's the only injectable. They may give themselves a shot of Toradol, which is an anti-inflammatory agent, and then use a suppository to shut down the nausea and vomiting. So it's really a 3-prong attack because the sumatriptan and certainly the Toradol are not going to necessarily stop the nausea and vomiting.
I was mostly asking because with MS, of course, if you have a lesion, you're going to have, lasting effect on the myelin sheath. So when I'm having a migraine, I'm wondering if there's some kind of lasting effect.
Well, that is an excellent question because studies have shown that, particularly in patients with a chronic migraine, that there is particularly the longer and more intractable migraines they have, that there is some brain cell death. So there's literature to support early intervention, early meaning early in a patient's life. That's why I encourage my patients with teenagers and children in their 20s to come in and see me. And if they don't see me, see some other headache specialist. And I explain all this to them because over a lifetime, there is a deleterious effect on the brain for uncontrolled migraine headaches, much like there is for untreated multiple sclerosis. Exactly.
We have one more question right here.
I know several people who try to control their migraines with diet. What are your thoughts on that?
Controlling migraine headaches with diet is an honorable endeavor. Unfortunately, it's not particularly effective. Now, as I said earlier, if you find that a particular food, certainly alcohol is off the chart, that's not acceptable because that's almost a universal migraine trigger. But if you find a particular type of food, processed meat, aged cheese, other preserved items, things that have yeast in them, certain baked breads, if you find that a particular food substance consistently triggers your migraine, then you need to avoid that particular food or group of food items that consistently trigger migraine. And those patients know, and they do avoid that, but they still have the migraine disease process. Again, it's a disease process, much like high blood pressure or diabetes. Most patients cannot particularly control their high blood pressure, diabetes just with diet alone. And so trying to do patients with chronic migraine, whether it be high frequency episodic migraine or otherwise, usually fail at that endeavor. But I would encourage a good and more healthy diet and avoid the food triggers that trigger migraine.
Excellent. Thank you for your presentation.
Okay, thank you
Everybody
all.
give a round of applause. Let's thank Teva again for supporting this. Thank you very much.
Thank you.